So good evening everyone. I hope you are good and we are all done for the clinical case discussion for today. Please let me know if my audio video is clear and I have started with a very simple question because simple things may be missed sometimes, but they are really important. And as we are heading towards the examination, my main aim is that along with revising the complex things, the clinical scenarios, we actually stay connected with the most important topics, the previous year questions, as well as the topics which are frequently repeated. Hello everyone, how are you? And one more thing guys, just for your update, we will be conducting the ophthalmology doubt session also on Monday. That is your 4th of April, 8:30 p.m. in the evening sharp. So be ready with all your doubts and I think we'll have a great time. I'll be talking about the GT scores also. We will be talking about GT scores. I know many of you are actually having a problem related to that. I have got so many, queries related to the GT scores. At times you have stagnation and we feel that it's not improving. How to improve upon it? You are really working hard day and night. So we'll be talking about that also and be ready with all your other questions as well as your ophthalmology academic doubts. Hi everyone. Hi Ganesh, Kirti, Astha. Hi Astha, how are you? Long time. So yes. So can you tell me what is it a boy is presenting with diplopia? And guys, I want everybody of you to answer in the comment section. And also what you can do, you can tell me the topics that you want me to talk on 4th of April. So we'll be talking on those topics also. We'll be discussing certain important things, certain important cheat codes, certain important mnemonics, certain important questions related to that, along with your queries. Because always we feel that there are certain topics that we always have difficulty in. So I think that will be a great time that Hi, Miracle Library. So your name is really interesting, Miracle Library. So I hope you people are doing fine and this is again an important topic that we are starting with. So please let me know if you know this answer. We'll be talking about this. Hi Vishal, hi Robin. Thank you so much. It's always my pleasure and I'm very lucky to have the audience like you, and I get a lot of love from all of you, and that actually motivates me to come even with newer things and newer mnemonics, newer mantras. I hope you are liking that also, because the main thing is the recall. So how to recall the different things. Yes. Okay, so a boy is presenting with a diplopia and restriction of the eye movements is also there following the blunt trauma. So this boy is coming with diplopia, restriction of the ocular movements, and the blunt trauma is there, and we have x-ray coming with the blowout fracture. So it's a very direct question, lots of stress due to exam. Yes, so we will be talking about stress also. Stress क्यों होता है? First of all, stress होता है whenever we have self-doubt. Stress means you are actually doubting yourself because you fear that you will be able to complete it or not. You will be able to make this time or not. You will be able to do it or not. So stress has no place, because that means self-doubt, and you don't have to doubt yourself. You just have to do your work. है ना? गीता में क्या बोला है? अपना कर्म किए जा, फल की चिंता मत कर. एक्चुअली उसको क्या होता है कि मेनी पीपल मिस इंटरप्रेट, उसको बोलते हैं कि फल की इच्छा ही मत कर. तो ऑब्वियसली बिना इच्छा करे फल की आप काम नहीं कर सकते. मोटिवेशन कहाँ से आएगा, है ना. तो इच्छा तो करनी है बट एक्चुअली चिंता नहीं करनी है. चिंता वो करेगा, गॉड इज देयर टू हेल्प अस, है ना. बाकी बहुत सारी चीज़ें हैं जो कि हम 4th of April को बात करेंगे. स्ट्रेस है, एंजाइटी है, सेल्फ डाउट है, फीलिंग लो है, लैक ऑफ मोटिवेशन है, लैक ऑफ इंस्पिरेशन है, एग्जॉस्टेड भी है. बहुत सारी चीज़ें हैं जो हम लोग बात करेंगे रॉबिन. तो प्लीज़ अटेंड करो, डू अटेंड द सेशन ऑन 4th of April. तो बहुत सारी हम बातें उस दिन करने वाले हैं. तो इसमें क्या है कि वी हैव डायरेक्टली गॉट दिस क्वेश्चन दैट दिस बॉय इज हैविंग द ब्लो आउट फ्रैक्चर एंड दे आर सेइंग दैट व्हाट इज द, मुलई सेज हिंदी नो, हिंदी नहीं आती. आई एम सेइंग दैट whenever we have stress, we have actually self doubt. Why we are having stress? Because we are doubting whether we will be able to do it or not, whether I'll be able to make this time or not. So those are the things that actually leads to the stress. So if you keep on doing, this is actually the shlok of the message of the Bhagavad Gita, that keep on doing your hard work and destiny will definitely give you your required reward. So you don't have to worry about the results. You have to just carry on with your good work. I hope now I am clear. So which part of the orbit is most likely damaged? I think all of you have given this right answer. Yes or no? Yes. So all of you have given the right answer. That is your B. This is inferior wall. Now, what are the other things that I'll make it patla because it is, this is your inferior wall. Now, can you tell me certain other things? Which view we are going to do? Which view we are going to do? If you have the X-ray orbit, basically we are going to do the X-ray orbit. Okay, so which view we should do in cases of the blowout fracture? Give me this answer. We will be talking about the related things that could be asked. So what is the view that we are going to do in cases of blowout fracture? This is an important topic because this was asked in the Neet 2018 also and Neet 2019 also. Image based question tha 2019 mein. It was an image based question in 2019 and 2018 mein it was a direct question. So can you tell me what is the view? What is the name of this view which is actually required? Which view we are doing in cases of the blowout fracture? So inferior wall is there. Vikram, do you think it is the oblique view? I don't think so. Please correct. See what is the view that we are going to do, and there is a special name of name also, because what we want is that the rays should go to the inferior wall. The rays should go to the inferior wall, right? So what is that view called as? Where rays will directly penetrate the inferior wall of the orbit and then we are going to get the thing. So we have got either all four options. Okay, oblique view, AP view, re view, Caldwell view, lateral view. So and then we have Waters view. We have got 6 options. Which of the following is correct? Who will tell this? Which of the following is actually correct here? Please let me know. People are asking what to read in the Parsons. Okay. So which view is correct actually? Yes, so I think now you people have started giving the right answer. Actually, it is the Waters view. It is the Waters No, it is actually the water's view. Please make this correction. It's a very, very basic question, and we are expecting many questions on this topic. There are certain things which you cannot actually skip for your upcoming exam. So I think I am very happy that I have kept this topic, and I am able to correct you guys. See, all of you, please note this, and as I told you before also, please make a notebook of this and keep on adding the things, whichever things you do not know or you have some confusion, the clinical scenarios that we are discussing actually, we will keep on doing. And the important things, it's important that you can jot down. Please jot down the things that are very, very important. First of all, the inferior wall, Then second is that we are doing the water's view. Water's view means the person has to remain as if he or she is drinking the water. So when we are drinking water, the rays are directly going to the inferior wall. That is why this is called as water's view. Now, as you know that the fracture is actually common in the inferior wall. Now, what are the other things that you two need to know with respect to the walls? What are the simple things? So we will revise important things related to the orbit. First is shape of the orbit. We will revise quickly one-liners, because 30% will be one-liners now. 30% of the questions will be your one-liners of the basic things. So we are taking it that. First, what is the shape of the orbit? Number 2, the thinnest wall. Which one is the thinnest wall? Number 3, which one is the thickest wall, thinnest wall. So keep on answering, guys. 1, 2, इस तरह से you keep on answering. Number 4, what is the volume of the orbit? What is the shape of the orbit? What is the thinnest wall? Which one is the thickest wall? Volume of the orbit. And number 5, what is the angle between the medial and lateral wall? Medial and lateral wall of the orbit. So let us see how many questions we have got the answers. Okay. Shape of the orbit. Shape of the orbit, guys. What is the shape of the orbit? The shape of the orbit is like this, which is holding, I'll show you, which is holding the eyeball, something like this. Always remember. So it is doing the different ones. It is doing the different actions like this: elevation, depression, adduction, abduction. Can you see? So this is the shape of the orbit, and what are the actions we are doing? We are doing elevation, depression, adduction, abduction. Okay? Then internal rotation, intorsion, external rotation, extorsion, and that reminds me of squint. Next time we will definitely do questions related to squint. Squints are related questions we will do. Okay? So, what is the shape of the orbit? Shape of the orbit is pyramidal. Pyramidal, or you can say conical. Question number 1 is this. Which one is the thinnest wall, guys? Thinnest wall is your medial wall. Medial. And which one is the thickest wall? 2. Everybody has given the right answer. Medial wall. What about this thickest wall? Volume. Volume is also, Ganesh, 32. Have you read this 32 specific anywhere? I think it's 30 ml. You are very close. 30 ml. Okay. And Ganesh, you are again right. What is the angle between medial and lateral wall? It is 45 degree. So which one is the thickest wall? Nobody has answered thickest wall. Can you imagine? Kirti, it's not 90, beta. See, how to actually do it. See, this is your medial wall and this is also your medial wall. Okay? These are the two medial walls, and then we are going laterally here and we are going laterally here. Okay? So this is your orbit. Then this is the apex of the orbit, apex, and this is the base. Towards the base, if you see, base is actually the quadrangular one, and base is your quadrangular. This is base, which is quadrangular. Quadrangular. Base is quadrangular. ठीक है. Now this one is your medial wall. This is the lateral one. This is superior, which is also called as roof, and this is the floor is your inferior. ठीक है. Now what is the angle? ठीक है. Angle में, if you are joining the back areas of the lateral wall like this is your 90 degree. This angle is 90 degree. So what is this angle and this angle between the medial and lateral? 90 by 2. So 45 degree, 45 degree. 45 degree and 45 degree is this one. And inside this we have the eyeballs like this. And here also we have the eyeball like this. And we have something coming out here. This is your optic nerve. This is the optic nerve. Have you drawn it, guys? So which one is your thickest wall actually? It is the lateral wall. Thickest wall is the lateral wall. These are the related questions. You can take a snapshot, or you can, if it is better that you write it in your own one. Okay, so you were saying 30 only, then it's very good. Okay, lateral wall. Yes, thickest is the lateral wall. So shape of the orbit हो गया, then thinnest wall हो गया, thickest wall हो गया, volume of the orbit हो गया, the angle between medial and lateral wall. Then we have this diagram, and the two important thing is that the medial walls are parallel to each other. Medial walls are parallel to each other. Another important thing, while the lateral walls are perpendicular to each other. It is perpendicular to each other. Medial walls are parallel to each other and the lateral walls are perpendicular. So we have done the most important question, then we have done the related questions also. Is this clear, guys? ठीक है? Alright, now coming to the next one. Now another important clinical scenario. Please see it. How to go about it. Now, see. Of late, some people were asking me how to actually go about the time, how to reduce the time to read a particular question. So whenever you get actually this long type of question, always read the last line first. Which of the following is the most appropriate next step in the management? So basically you will come to know that actually they are asking about the treatment. We have to focus on the treatment. Now we will read the question and you will tell me the answer, right? We have a 74-year woman who is coming to the physician because of progressive blurring of the vision. So age is 74. We have a woman, we have a progressive blurring of vision. And about 3 years ago, she stopped using her reading glasses for several months. Now, you will have to give me several more diagnoses also. What is the diagnosis here? About 3 years ago, she stopped using her reading glasses because her eyesight improved temporarily. Can you tell me the diagnosis? where there is an improvement in the near vision, where the patient can read even without the reading glasses. This is your question number 1. So question number 1 is this, where the patient is able to read even without the reading glasses. What is this? She is a landscape painter. Now she has mostly been working inside a studio instead of outside. Why? Because the bright sunlight makes me see more halos and I cannot distinguish between the colors. What is this? This is your question number 2. This is question number 2, where the patient is not able to tolerate the bright light. So question number 1 is where patient can read even without the reading glasses. Even without the reading glasses. Question number 1. Number 2, we have intolerance to the bright light. What is this called as? If we have intolerance to the bright light, can you tell me this before going to the final one? What is this actually called as? Yes, so if the patient can read even without the reading glasses, then this is actually your second sight. This is the second sight, and second sight is found where? Where it is found and why it is found? Your next 2 questions. Then we have got intolerance to the bright light. What is this called as? What is this called as intolerance to the bright light? So you have to answer this also. Meanwhile, we are coming here. The patient recently stopped driving at night because she is not trusting her eyes. So there is a problem. This is your question number 3. Because she is no longer trusting her eyes in the dim light. So your next question will be, if we have clumsy vision. If we have the clumsy vision in the dim light. If I have more of the clumsy vision in the dim light, then what we can expect? See, if I am having a second sight, where I have this in the nuclear cataract. And why do I have this in the nuclear cataract? Due to the progressive index myopia. Due to the progressive index myopia. See what happens if I have this nuclear cataract. Now this is again very, very important. If I have this nuclear cataract, this nuclear cataract is called as sclerosis. Okay? Sclerosis. Now sclerosis actually means hardening. We have hardening of the nucleus. This hardening takes place due to 2 things. What are these 2 things? One is the dehydration, and number 2 is your deposition. Deposition of the pigments. Deposition of the pigments. Sclerosis means hardening. Hardening is due to dehydration and deposition of the pigments. Now, if I have these 2 things, due to this, we have hardening. Hardening will lead to increase in the refractive index. Now, who will tell me the normal refractive index? Normal refractive index of the lens. Tell me the normal refractive index of the lens, what is of the nucleus and what is of the cortex. There is an increase in the refractive index, and due to the increase in the refractive index, yeah. So if I have increase in the refractive index, meanwhile give me the answer of the normal refractive index also, okay? So because you know these type of questions will be asked to you in your Viva Voce also, Viva. Even if you are doing the Viva Voce or your ward leavings, your internal examinations, you are going to be asked these things again. Myopic eyes can get back distance vision. Limo, you have to specify, are you telling about the nucleus or are you telling about the cortex? Increased refractive index will lead to what? Refraction index. So increase power. So this is actually leading to the increase in the converging power. So if the power is increased, rays will be focused before the retina. So this person becomes myopic. That is, we have progressive index myopia. Progressive index myopia. So this person develops progressive index myopia. Now once this person develops myopia, we have short sightedness. We have the short sightedness. In the short sightedness, we will have the improvement of near vision. We have the improvement of the near vision, and due to this improvement of the near vision, patient can read even without the glasses. So now the patient is able to read even without the myopia. This is clear, guys? Yes. Limo, thoda sa, you are very near. Refractive index of the lens में it is 1.39 to 1.42. ठीक है? So nucleus का it is actually 1.42 and cortex is 1.39. So you have to take this range. You have to take it as a range, guys. And what about this? What about this? What is intolerance to the bright light? Intolerance to the bright light is actually your glare. This is the glare. Now, what is the difference between the glare and photophobia? Because some of you have actually mentioned photophobia. Now, let me tell you that also. One thing is actually glare and one thing is the photophobia. One thing is the glare and one thing is the photophobia. Glare actually, yeah, you were very close, right? So glare is actually the intolerance to the bright light. If we have very, very bright light and there is an intolerance to this bright light, it is a glare. Photo and phobia. Photo means light and phobia is a fear. So this is actually the fear of the light. So if the patient is having a fear of even the normal light, this is your bright light. Photophobia means eye closure. Very good. Yes, the patient will close the eye because here we have a fear of even the normal light. So glare can be normal also. Even if a normal person will go in a bright sunny day, he or she will have this glare, light sensitivity, will have the intolerance, but photophobia is always pathological. Now, one thing more, that is again a good news for you guys, because you were lacking that clinical exposure during the pandemic crisis and you really require this for your next two also, as well as your Viva and ward leavings. We are bringing the clinical Wednesdays for you people, Right from the coming week, we will be bringing the clinical cases, how you have to take the history, how the case has to be presented, what are the common questions that you are supposed to be asked during that, what are the things that you need to examine in the patient. You will all be getting this in the form of YouTube sessions. Every Wednesday we will be giving you one case. So it will be starting with your cataract case. I think that is universally important, right? So I'll be telling you all the important things related to the history and examination of the cataract. So be there right on the clinical Wednesdays. I think it is going to be very, very interactive, right? So all the things related to this, I think you must be watching your me there running after that guy also and explaining him everything. So keep watching that. Yeah. So can you tell me any example where you will get photophobia? Any example where you are getting the photophobia? Where you will get photophobia, guys? And what is the clumsy vision in the dim light? Clumsy vision more in the dim light. That means it can come under the DD of the night blindness. DD of the night blindness. It will come under. Now, because I am saying that this patient is having the second sight was in the nuclear cataract. So, we have got a diagnosis of cataract here. Now, cataract will have glare also. That is also related. So, which cataract will give you night blindness? Now, a question, your next question number 4. Which cataract will give you night blindness? Like, if I talk about the senile cataract. If I talk about the senile cataract can be cortical also, or it can be nuclear also. Cortical cataract may we can have cuneiform and cupuliform. So I have made certain things easier for you. Now can you tell me which of these cataracts will cause more of night blindness? Hi Deepthi, good evening. Ganesh, can you give me one example where you will get example of the disease? Saranya, okay. What about others? Which cataract you will have clumsy vision in that dim light? Meanwhile, we'll be reading this question. Limo, can you tell me what is the meaning of cupuliform cataract? What is the meaning of that? So let's finish the question also. She is also having the history of type 2 diabetes. We have asthma, we have atrial fibrillation, and we have got smoking cigarettes for so many years. Wine is also there. Medications may we have metformin, albuterol, budesonide, digoxin, everything is there. Temperature is 37, pulse is 89, irregular, respiration is 13, BP is 135 by 82. Visual acuity is less, 20 by 80. On fundoscopic examination, retina is hard to visualize and reflex is not seen there. Retina is hard to visualize. So we have got hazy media. We've got hazy media here. Which of the following is the most appropriate next step? Laser photocoagulation of the retina, discontinuation of the digoxin therapy. What are the side effects of digoxin? Another important question. Surgical replacement of the lens or the topical administration of latanoprost. Come on, give me the answer. I have discussed everything and then we will be discussing the okay. Yes, Limo, you are very, very correct. So it is posterior subcapsular. Posterior subcapsular कैसा होता है? Let me show you the picture, guys. You have given me the right answer. Posterior subcapsular की बात करते हैं. Yeah. Hi Prateek. Of all the YouTube sessions, which all YouTube sessions? This clinical case discussion or all YouTube sessions? You have to specify. Yes. So see everyone, this is your cupuliform cataract where you have the plaque-like area just in the center. This is your slit lamp finding. Slit lamp pe you can see. Can you see this one? We have got the central plaque-like area. So if I have opacification in the center, what is going to be done? Suppose this is the iris and this is the lens here. Now the center of the lens is having the opacification, something like this. Suppose the center is having this opacification. So it will have more problem during the day or more during the night. If I have, this is actually rather nuclear one, we'll make it posterior subcapsular is here. So if I have the daylight, in the daylight the pupil is constricted. So when the pupil is constricted, now the rays can pass only through the center and we have opacification in the center. So posterior subcapsular cataract or the cupuliform will have more problem in the daylight. Are you getting this? Now if I talk about the other type of cataract, this is your cuneiform. Cuneiform mein we have the wedge shaped areas like this. Wedge shaped areas which are actually coming from the periphery. This is from the periphery towards the center. From the periphery towards the center. So what is happening now here? Suppose we have got iris and then we have the lens. Here we have opacification which is present in the periphery here. So when it is going in the dim light, pupil is dilating like this. So now the pupil gets dilated. So the rays will be passing through the periphery. Center one will pass but the peripheral ones will not be able to pass. So basically the clumsy vision in the dim light will be more in the cuneiform type of cataract. Are you clear with this? One of the commonest pathology leading to photophobia is migraine, glaucoma. Okay, which glaucoma? Which glaucoma? Digoxin causes yellow vision, that is okay. And uveitis is also okay. Corneal ulcers. Corneal ulcers, basically the bacterial corneal ulcers will be going with this. So we have got the yellow vision also, that is also correct. So coming back to this one, so basically night blindness is mostly caused by the cuneiform and that is most common also. This cuneiform is actually the most common type of the cataract. Out of all the cataracts, it is the senile which is most common, cortical which is most common and this cuneiform, very good. So it is actually the open angle type of glaucoma. So basically now when we have discussed everything related to this question, can you tell me the answer guys? What should be the management? What is the diagnosis of this patient? फिर से read करेंगे. 74-year women है, progressive blurring of vision है. For some days she was having, she was able to read even without the glasses. So there was nuclear sclerosis. She has also a history of glare. She had history of night blindness. She is having diabetes, asthma, atrial fibrillation, smoking also. And she is having hazy media. So what is the diagnosis of this patient and what is the treatment? Can you tell me the answer now? Anybody who can give me the answer now? We have the laser photocoagulation of the retina, discontinuation of the digoxin therapy, surgical replacement of the lens or the topical administration of the latanoprost. Who will tell me the answer? Diagnosis and the treatment. Diagnosis and the treatment. Topical administration of latanoprost is given for the open angle glaucoma. In the open angle glaucoma, I can get the night blindness, but I will not get glare. I will not get the second sight. Extracapsular cataract extraction with the PCIOL implantation. Yes, exactly. Then therefore this is not the answer. Where do you do the laser photocoagulation of the retina? Like for the PDR we do. So this is not a case of diabetic retinopathy. Digoxin mainly causes your yellow vision. and it also causes the optic neuropathy. So this is also not there. So your answer to the question is the surgical replacement of the lens. So I hope you have understood this. We have seen question related to the orbit, everything around it, and then question related to the cataract also, right? Okay. Okay, now see this. This is again an interesting question and a squint question also. Which of the following investigations needs to be done for the initial evaluation of a child who is actually presenting with the following symptom? What is this actually? What is this? And then we will discuss that what should be done in this patient. Can you tell me? Can you tell me what is this in the patient so that we can discuss? Let me see how many of you are giving the right answer of this. First of all, you have to just tell me the sign. What is this? And then we are going to discuss that what has happened to this person. Acha, can you tell me the difference between a phoria and a tropia, guys? Phoria and a tropia. Now you all can see that here actually we are having the squint. Okay? You can see this is squint. Now can you tell me, is it latent or is it manifest? Is this a squint latent or manifest, guys? This is a very simple question that we can expect in the squint. You can get a spot diagnosis in your third prof also. So is it actually the latent squint or manifest squint? You can see this now. Because you can see this is squint. So this is actually a manifest squint. It is not latent. ठीक है? तो अगर हम latent बोलेंगे, if I talk about the latent, that is actually phorias. But the manifest is the tropias. Manifest is the tropias. This is latent is phorias. So can I say it esophoria? No. This is actually esotropia. So this is actually a difference between a latent squint and a manifest squint. Now what are the tests that we can do to differentiate between the latent and the manifest squint? Why do we have the latent squint? What is the treatment that we are going to give? These are the different things that we need to know about this. Yes. So obviously this is a case of a manifest squint. So this is a case of, this is your right eye and this is the left eye. So this is your left esotropia. Okay? Now what is the test that we are going to do? Is it a forced duction test, cover uncover test, fundus examination or slit lump examination? So obviously phoria is manifest when both are not looking at yes, phoria becomes manifested when the fusion is broken. Okay, now what is forced duction test? Let me tell you that also. What is forced duction test? Forced duction test is actually used to differentiate. It is used to differentiate between the paralytic squint and your restrictive squint. Now what is this? Then we will be talking about cover uncover test also. See what happens whenever we have got the incomitant squint. Incomitant. In cases of the incomitant squint, we can have paralytic also, we can have restrictive also. This is due to the palsy and this is due to the fibrosis. Okay. So the muscle is not working either because of its paralysis or it's not working because of the fibrosis. That is, we have mechanical restriction. We have mechanical restriction. Okay. Now, if I want to differentiate, what can I do? So what can I do is that you first instill the local anesthetic in the eye and you ask the patient to look in the direction of action of the paralyzed muscle, so that we are not actually having any restriction, any resistance in that direction. So we ask the patient to look in that direction. And now what you do, you hold actually the eyeball at the limbus. We are holding with the help of a forceps, okay? And we try to drag this eyeball which we are holding at the limbus in the direction of action of paralyzed muscle. In the direction of action of paralyzed muscle. So if I am able to drag something like this, there is a passive movement. So what I am going to do, suppose there is no mechanical restriction. If I am moving it like this and there is no mechanical restriction, that means force duction test is negative. And if yes, if the restriction is present, then we will say forced duction test is positive. So if the test is negative, that means it is a case of the paralytic squint. Then it is a case of a paralytic squint because there is a palsy, because restriction is not there. But if it is positive, then it is a case of your restrictive squint. So basically it is not for esophoria or exophoria. It is to differentiate between paralytic squint and the restrictive squint. Now this is a case of a squint where we have right. So here what we are doing, suppose we are suspecting that patient has a latent squint, but we have the fusional reserve. Now what is this fusional reserve? We will try to understand this. See, we have got 3 grades of binocular single vision. 3 grades of binocular single vision. First, we have simultaneous perception. First is the simultaneous perception. Number 2, we have fusion. And number 3 is the stereopsis. Then we have the stereopsis. So only when we are able to see both the things simultaneously, then there is a fusion and then we have the third dimensional aspect. In cases of the latent squint, we have this fusional reserve. So for small degrees of squint, the muscles have a fusional reserve. So they are able to maintain the fusion and therefore squint is not manifesting. That means for the testing of the latent squint. So if I want to test the latent squint, basically I will have to break this fusion. Okay, na? So we have to break this fusion. If there is no fusion, then the squint will manifest. Now how can you break this fusion? By stopping the simultaneous perception. By stopping the simultaneous perception, because if I have no simultaneous perception, I will have no fusion and therefore no stereopsis. So how can you stop the simultaneous perception? That is very simple. If I cover one eye. Now if I cover one eye, suppose something like this. Something like this. So moment we cover the eye with the help of a occluder. If I am covering the eye, there will be no simultaneous perception. No simultaneous perception means no fusion. and squint will manifest. And therefore the squint will manifest. Now you are not able to see it, but under the cover, eye is actually deviating. Now because the most common squint is either inward or it is outward. So I'm going to have either EZO or I'm going to have EXO. Okay? So how will I get to know? So moment you uncover it. When I uncover it, again, when I uncover it, again I will have simultaneous perception. So again I will have fusion and therefore no squint, and squint will go. So as soon as you uncover it, I will move to take the original position. So this movement to take the original position is actually recovery movement. So EZO will go outward. EZO will go outward to take the original position, and EXO will go inward to take the original position. What is this called as? This is called as recovery movement. This is called as recovery movement. So recovery movement will always take place in the opposite direction. Now, whenever we have the latent squints, how can I treat it? Anybody who can tell me the steps for the treatment? We have to go in a definite manner. Exactly. So you people are very correct. The Sachin, Deepti, Limo, Aman. Yes, it is a ganda topic, but you cannot, escape it. You have to actually read it. So this is your cover and cover test. Now the second thing that we can do to detect it is actually the Maddox rod test. Maddox rod test also we can do. Maddox rod test actually create the dissimilar images. It creates the dissimilar images, and in the dissimilar images we have no fusion. We have no fusion in the dissimilar images. Therefore again fusion will break. How? Now let us see that. Suppose this are the eyes, and we are suspecting the squint. Actually we do not have any, we cannot see any squint. Now what we do, we cover the eye with the Maddox rod. So first of all, what is Maddox rod? Maddox rod mein you have got actually the different cylinders capped over one another. So we have got number of cylinders which are capped over one another. Now when cylinders are capped over one another, what they are going to do, they actually convert the point source of light into a fine line. ज़्यादा thick हो गया था. It is actually converting it is something like this. Okay. So basically this Maddox rod converts point light into a red line. मतलब a point source of light है. So normal eye will see a dot reflex only. Suppose I have covered one eye with the Maddox rod and other is seeing normally, and the patient is asked to see a light. Now the eye which is covered with the Maddox rod will start seeing a red line. Okay? And the other eye will see a dot reflex only. Now why this is a red line? Because Maddox rod is red. Okay? Rod, R for R से याद रखो, rod is red, and this line is actually perpendicular to the axis. So if we have horizontal squint, I'll keep it horizontally like this. So if we have horizontal squint and I am keeping it horizontally, line will be vertical. If I am keeping it vertically in vertical squint, line will be horizontal. So this eye will start seeing a line while the other eye will see a dot reflex. So we have dissimilar images. Dissimilar images में no fusion, and therefore this person will start having diplopia. So basically this will be the complaint of the patient. Patient will tell you that with one eye I am seeing a red line, with the other eye I am seeing a dot reflex. Both are different. So if the person is having diplopia, squint is there. Okay, so 2 important tests you will remember: cover uncover test in Maddox, rod test, and we will revise them again in the next class also, because I know they are little tough. Okay, now the treatment part, the treatment of the latent squint. Treatment of the latent squint के लिए we have got a important mnemonic. This mnemonic is COPS. This is your one mantra for today. Mnemonic is COPS. COPS means the police. You have to go in this order. So first we have to do is C. Second we have to do O. Third we have to do P. And fourth we have to do S. So who will tell me what is the C? Yes. So first what we have to do? First we have to do is C. C is your correction of the refractive error. First we do is the correction of the refractive error. O is the ortho-optic exercises. Ortho-optic exercises. Why we are doing this ortho-optic exercises? To improve the fusional reserve, because muscles have gone into fatigue. They are not able to maintain the fusion. So we are increasing that. 3 is the prisms. We have to introduce the prisms. And 4th is the surgery. What is the ideal age? It should be after 5 years of age. What is the age of the surgery? 5 years of the age. So is it okay, guys? Have you understood the latent squint, difference between phobias and tropias, difference between the restrictive and the paralytic squint, then cover uncover test, Maddox rod test, and the treatment of the latent squint also? Any question related to this, guys? Any question related to this? Now, how can I go without giving you, pearl for today, a mantra for today? So we all know that ectopia lentis is an important topic, and you get to be asked about the causes. The causes of the ectopia lentis. So if I have a case of ectopia lentis, what I'm going to tell to my colleagues or my juniors, my students, I will say, I'll fix it. Okay, na? I'll fix this ectopia lentis. So your mnemonic is will mash tapes. Means I will tape it with the mesh and I'll fix the ectopia lentis. Okay, will fix the ectopia lentis. So the thing is, will is your Weil-Marchesani syndrome. Will is Weil-Marchesani syndrome, and then we have mesh. M-E-S-N-H. Mesh. M-E-S-H. So what is M? M for Marfan syndrome. E for Ehlers-Danlos syndrome. S for Stickler syndrome, and H for homocystinuria. And you always get question on Marfan's and homocystinuria. We were having in 2021 also the question. Now, can you tell me the genetic inheritance of Weil-Marchesani syndrome, Marfan syndrome, homocystinuria? And meanwhile, I will tell you the tapes. So we will fix it with the tapes. T for trauma. Yeah. A for aniridia. P for pupillae, and then we also have the pseudo exfoliation syndrome. Pseudo exfoliation syndrome. And finally, E for ectopia lentis. You are going to get ectopia lentis and pseudo exfoliation syndrome and aniridia, trauma. Then we have Marfan syndrome, Ehlers-Danlos syndrome, Stickler syndrome, homocystinuria, mesh, and Will is the Weil-Marchesani syndrome. Have you told me the genetic inheritance, guys? Can we perform this surgery in paralytic squint, and is this useful? Aman, actually, most of the times we have surgical causes of the paralytic squint until and unless it is due to the hypertension or diabetes, and it is useful. Suppose we are having the palsy due to space occupying lesion, due to any aneurysm, due to the this tumor, so obviously that will help. Surgery only will help. So obviously it's useful. So what is the inheritance pattern if I talk about, guys? So in Weil-Marchesani syndrome, it is actually autosomal recessive. Marfan syndrome, autosomal dominant. Homocystinuria is autosomal recessive. Now we will end for today's session with a question: which enzyme is deficient in homocystinuria? So this is your question: which enzyme deficiency? Which enzyme deficiency we are having in the homocystinuria, and what is the treatment? This was asked in 2021 previous year question. It is always asked. So let me actually ask you, and I know you will definitely give me the answer. Please give your feedbacks also about the session. You also get to know that we are coming up with the clinical Wednesdays and the doubt session of ophthalmology on 4th of April. Please get ready for all your doubts, academic as well as stress related, GT scores related. I'll be answering everything there. And be ready for your clinical sessions on clinical Wednesday. We are going to have amazing interaction in the cases of all the subjects, and see you next week again with the clinical case discussions, and keep on answering this question, that what is the enzyme deficiency here and what will be the treatment. So keep on studying, keep rocking, guys. Goodbye. Happy ophthalmology.